My name is Dr. Gautam tawari, and I'm going to talk about decavariance tenosynovitis. So decavariance tenosynovitis is essentially inflammation around the first compartment of the hand. This involves the extensor pollicis brevis and abductor pollicis longus. It is not a very uncommon disease, seen in 1 in 1,000. Essentially seen in women aged between 30 and 50 years, and often in dominant wrist, as that is the more used hand. The risk factors essentially is overuse. That is the most commonest cause, often seen postpartum, but can also be seen post-traumatic. The extensor tendons are placed in 6 compartments around the dorsal part of the wrist, and it is the inflammation around the first compartment. Often the etiology is said to be thickening of the extensor retinaculum along the first compartment of the wrist in the dorsal aspect. Patient often presents with pain around the radial side of the wrist, or essentially around the anatomical snuff box of the wrist. It is gradual onset and increases with use of the hand or gripping. Provocation test is an eponymous test called as Finkelstein's test, and you can see it is essentially by keeping your thumb in the palm and hyperulnar deviation of the wrist that causes pain. Imaging-wise, confirmation of the diagnosis can be done with an MRI scan. Otherwise, most commonest way of confirming the diagnosis is clinically. Treatment, like most things, is twofold. You have conservative treatment, which involves putting thumb spica splint for a certain duration of time and supplementing it with non-steroidal anti-inflammatories. Injections do work. However, in practice, it is often seen that the injections are temporary. Definitive treatment is release of the first dorsal compartment of the wrist. Incision are 2 types. It can be done with a transverse incision along the skin crease or a Brunner type incision. Each has its benefits and its disadvantages in terms of injury to the adjacent structures and visibility. These are what these incisions look like. One thing in mind, whilst releasing the tendon, please remember that APL, which is abductor pollicis longus, can often have 2 tendon slips. So releasing only 1 tendon slip can give you inadequate relief of the symptoms. For the sake of video, I have used a Brunner's incision because visibility is much better with the Brunner's incision. The Brunner's incision is made over the first compartment of the wrist, and skin subcutaneous tissue is separated. Care is taken that the dorsal branch of the superficial radial nerve is protected at all times. This can be at a risk in a transverse incision, and care should be taken for that. That is what you see, the shiny glistening structure is the first compartment of the wrist with the extensor retinaculum. I'm just opening the extensor retinaculum, and you can see fluid coming out of this. This is inflammatory fluid, often seen when this step is undertaken. This is what it always looks. Once the extensor retinaculum is released, we take the tendon of the EPB and the APL out of the sheath. So this is APB released. We've checked that there is no 2 slips, and that is how confirmation is done. The skin then is closed in layers, and the patient is advised to use their hand as normal. So first compartment, release of the extensor tendon. You can see the inflammatory fluid coming out. That is the EPB that is released, you can see. And then the APB. So it's a very straightforward procedure. Care should be taken about the superficial grade enough and expect really good outcomes from this. Thank you.